Hello, everyone. My name is Victoria St. Martin. I'm a breast cancer survivor. I was diagnosed when I was 30 years old, 10 years ago, and I am now a mom to a 21-month-old. With me today, I am excited to welcome Dr. Nikhil Wagle. He is going to discuss precision medicine and biomarkers in breast cancer. There's a lot of exciting developments in this arena, and I cannot wait to dive in further and learn more. Thank you so much for joining us.
Thanks for having me. Great to be here.
I wanted to let you know a little bit about Dr. Wagle. He is an assistant professor of medicine at Harvard Medical School, a medical oncologist at Dana-Farber Cancer Institute, and an institute member of the Broad Institute of MIT and Harvard. He is the deputy director of the Center for Cancer Precision Medicine at Dana-Farber Cancer Institute. Dr. Wagle leads a transitional research program in breast cancer and precision cancer medicine. His research aims to identify characteristics of tumors that might improve clinical decision-making for patients with advanced cancer. He also is the director of Count Me In, a nonprofit organization aimed at making it possible for cancer patients anywhere in the United States and Canada to be partners in cancer research. I'm excited. Oh my gosh. So first, tell me, what is precision medicine?
Well, thanks for that intro and thanks for that question. So precision medicine, I'm gonna use the way I think about precision medicine, which is a very broad definition. To me, cancer precision medicine is the use of information, whether that's information from the tumor, from the patient, from the patient's clinical history, to tailor therapies and to improve decision making. And really, what the phrase you hear often associated with precision medicine is the ability to choose the right drug for the right patient at the right time. And that's a shorthand way to say that not every patient is treated the same. And, cancer is not the same. Breast cancer is not the same. ER positive breast cancer is not the same. The more we look at individuals and individuals' tumors, the more we realize that there are important differences. And as we understand those important differences more and more, we recognize that that means that, we should tailor our therapies appropriately. So that's what precision medicine is. For a lot of people, precision medicine means testing the tumor using some sort of genomic test to test the tumor to look for particular mutations or other alterations in the tumor that might specify a targeted therapy that works really well in that tumor. And that's probably the most common thing people think about when they think about precision medicine. But I, again, would like to broaden that to think it's really any additional piece of information that we can obtain to try and tailor therapy. And I'll add one other point, which is that tailoring of therapy might mean a specific therapy, it might mean more therapy, or it might mean less therapy, right? Because for a lot of patients, they may not need as much chemotherapy or other drugs as we use. And precision medicine might help us say who needs less. And it also helps us think who needs more.
Tell me a little bit about how biomarkers play a role in precision medicine.
Yeah, great. So biomarkers, and I know in this series there's already been a little bit of discussion of biomarkers. Biomarkers are a way for us to learn something about the biology of the tumor or the biology of the patient by looking at some kind of a sample. Oftentimes biomarkers are things that we can test in the blood. Sometimes biomarkers are things that we test from the tumor. And sometimes biomarkers are things we test from some other sort of specimen, a saliva sample, for example. And biomarkers are all different. And each biomarker the goal of each biomarker is to help us make some sort of clinical decision. So I'll give you some examples of biomarkers. One type of biomarker is often used in patients with early stage ER positive breast cancer. And that is a test that looks at the tumor There are different versions of it. One of them is called Oncotype DX, which many people have probably heard of. And Oncotype DX, when you test the tumor, can help patients understand what is the likelihood of their tumor coming back in the future, and what is the likely benefit of them getting additional therapy like chemotherapy. That's a biomarker. It's a biomarker that when we find the results of that biomarker, it helps us steer the direction of future treatment. Another biomarker that we use is in the metastatic setting. And I know we've heard a talk on metastatic breast cancer as well. In the metastatic setting, sometimes we can test the tumor, and that will specify particular therapies that might work particularly well. Again, in ER-positive metastatic breast cancer, we have a recent approval of a drug called alpelisib, or Piqray, and that drug works well in patients who have a particular mutation in their tumor in the PI3 kinase gene, or PIK3CA. And so you could test someone's metastatic tumor, and in the 40% of patients who have this PIK3CA mutation, they might benefit from this drug, alpelisib. And for patients who don't have that mutation, you shouldn't use that drug because it's not likely to work. Same thing with immunotherapy. We have now immunotherapy available to patients with triple-negative breast cancer. And we're learning how to use immunotherapy best and in who it works for. But one thing we do know is it works for patients who have whose tumor express a particular protein. And so in those patients, that biomarker tells us we can use immunotherapy. You know, breast cancer is one of the cancers where precision medicine and biomarkers maybe has the longest standing use, because we take the original breast cancer biomarkers almost for granted at this point, but testing for ER and HER2 and deciding if someone has ER positive breast cancer or HER2 positive breast cancer or triple negative breast cancer, that's a biomarker. And that's a biomarker that tells us, everything we need to know about what therapies to start with in a patient with breast cancer. So those are some examples. There are more. I actually think I'll add one more for this group. Another type of biomarker happens in the germline, right? It's the genes that are inherited from one's parents. And for young patients with breast cancer, there's an increased likelihood that there is some inherited susceptibility to breast cancer. That might be in the BRCA1 gene, might be in the BRCA2 gene. There are now even more genes that we know cause increased risk to breast cancer, like PALB2, and there are others. And so those are biomarkers that aren't part of the tumor necessarily, but also help us specify therapy. And now there are therapies that have been approved for patients who have germline mutations in BRCA1 and BRCA2. So you could see that biomarkers are important because the more we learn about them and the more we test, the more specific we can tailor people's therapies.
Aside from using biomarkers to determine the types of breast cancer someone has, how is precision medicine being used to predict things like drug dosing and response to treatment?
Yeah, great question. I'd say we have more to learn in those two areas, but I think it's a good question to highlight what the potential of precision medicine is and what we might be able to use them for. Drug dosing is one that we typically don't use biomarkers to choose a dose. Right now, for the most part, we have standard doses, and if the dose is causing too many side effects, we might lower the dose or we might switch medicines, but those aren't typically chosen based on a biomarker. There are some chemotherapies that we do choose based on a biomarker, but those are chemotherapies that are typically used in other cancer types. And to be honest, they don't always use the biomarker. They still do that same, trial and error approach, or, try it and change it if you need to. But I think there's promise for biomarkers for drug dosing. And as we get more sophisticated about our drug dosing, I imagine that there will be a role for biomarkers. Response to therapy is a really great one because, like I said, we might have some kind of standard of care therapy that we use, let's say in metastatic breast cancer or even in early stage breast cancer. but we know that not everyone responds the same. And even people for whom the drug works, sometimes the drug might work in some people for 6 months, and in some people it might work for 2.5 years, right? And so what's different between those two people? And we're increasingly learning that there might be some additional nuanced biomarkers that might predict why some people do better than others with a particular drug. And the reason that's important is, one, we might be able to, again, tailor people's therapy, but also it might help us with drug development. So we can either add something or change the drug or change the way we're using the drug so that everyone becomes that person that responds for 2.5 years instead of 6 months or less than 6 months.
Tell me, what are some of the obstacles and limitations to precision medicine and biomarker testing?
There are a lot of obstacles, both in the research side, the development of this kind of research and our understanding of biomarkers in precision medicine. And then there are a lot of barriers in the implementation and the use of this kind of information by patients and doctors. So let me start with research. I think, one of the issues is that our knowledge is, and how we use biomarkers is only as good as our ability to study patients. And so it is coming, that information comes from people who participate in clinical trials, people who volunteer to share their specimens with researchers, people who are willing to share their clinical information with researchers. One of the challenges is making sure that those patients, even when they do share their information with researchers, that the patients are representative of everyone who gets breast cancer, right? If we are not including everyone who gets breast cancer, and here I'm particularly talking about patients who have historically been excluded from research, Black patients and Hispanic patients particularly, who have not been included in these type of studies, then even when we do learn, we don't know if what we learn is applicable to everyone, right? We have bias in our findings. So some of the challenges in research is making sure we have enough patients to who are participating and studying, and also making sure that we are being inclusive when we do have enough patients. In terms of implementation, even when we do learn something, we got to make sure everyone has access to that type of care and that type of information. Even, when we have the best care, best possible precision medicine approaches, those are useless if someone's not getting tested. And they're useless even if someone's getting tested if they don't have access to the drugs that go along with that. So that is about education, both of the patients as well as of the clinicians. It's about finances, and it's about affordability of this type of care and these types of drugs, and it's about the availability of this care in the community, right? If people have to go to only a handful of academic medical centers to get this type of care, it's not helpful to the vast majority of cancer patients. So I think we have a lot of challenges. There's incredible promise in this kind of research. I mean, the kind of things that we're discovering right now are extraordinary, and it's really a golden age of cancer research. We just have to make sure that we are doing our part to make sure that everyone's included, and that when we do discover things, that it reaches everyone.
Tell me, what is the future of precision medicine for breast cancer specifically? Yeah.
Well, I think there are a couple of really exciting areas that are going to be really transformative for patients with breast cancer. In the metastatic setting, I think we are learning more and more about really specific subgroups of patients with breast cancer. And that is being accompanied by the development of new, really tailored, really targeted drugs and immunotherapies. And so the future of metastatic breast cancer, my hope is we will be able to test patients' tumors, and not just for a subset of patients, but for every patient, we'll be able to say, you have this combination of these biomarkers, that means you need this combination of drugs. And we will get longer responses and hopefully even cures in the metastatic setting when we can do that. I think in the early stage setting, our goal is to understand who is at high risk of developing a recurrence and metastatic disease, and being able to take care of those patients better with better drugs, smarter drugs, better monitoring, and also understand who is not at risk, who is at very low risk of developing recurrent cancer or metastasis and be able to spare those patients really toxic or aggressive therapies. And there's some really exciting work right now being done with understanding people's risk of developing future recurrence, particularly through liquid biopsies. So liquid biopsies are being able to draw blood and get a picture of the tumor from a blood sample. And so if you can monitor someone's blood after they have surgery for early stage breast cancer, one, you might be able to say who's at risk for developing a recurrence, a year from now, 5 years from now, 10 years from now. And maybe if you can figure that out, maybe those people need some extra therapy to prevent that from happening. Maybe you can detect when a recurrence does happen, but detect it really early, right? Before it actually shows up in the body. It just shows up as a small microscopic amount in the blood. And maybe you can intervene and prevent that cancer from ever coming back. And then maybe you can identify those patients who, the cancer is eradicated and it's not coming back, and therefore you can just ease up on the therapy. So I think that's a hugely promising area for people with early stage breast cancer.
How can young adults help move this research forward, whether or not they already have been diagnosed or completed breast cancer treatment?
Yeah, I touched on this a little bit already, which is that
Yeah.
our research and our ability to make this kind of information available about precision medicine is strengthened by participation, right? The more people participate in this kind of research, the more we will understand. What I like to say is there's strength in numbers, right? The more people who are participating in this, the more we'll see, the more patterns we'll understand, the more we will understand, the different groups of patients that respond differently to different drugs. And so it is about partnering with patients to be able to accelerate this type of research. And so, you mentioned at the beginning that I direct this initiative called Count Me In. And this is the idea behind Count Me In. Count Me In is a program that allows patients with cancer, in this case, patients with breast cancer, regardless of where they live in the United States or Canada, to volunteer and say, count me in. It's okay with me for you to look at my medical records and get information from me, learn about my experiences, collect a saliva sample, collect a blood sample, go to my original hospital where I had my breast cancer surgery and get a portion of my tumor tissue. So we do all that. And when people volunteer, we collect all that information, we generate the data, we make it publicly available to all researchers, and then all researchers can together work on this massive data set to try and advance this kind of research. So Count Me In is open to all patients with cancer. It's open to young women who have breast cancer or who have had breast cancer in their past. And there's been thousands of patients with breast cancer who have already signed up, and we're hoping for thousands more to sign up because we're really, I think, going to be able to speed this up. So I'll make a shameless plug. The website for Count Me In is joincountmein.org. And you can just go there and read about it and sign up. And if not Count Me In, I'd say participating in research, wherever you are, your local cancer center, is a huge help. It benefits all of us.
I love that. Count me in. I am going to sign up. It's
Great.
amazing.
Awesome.
Thank you so much for all you are doing and all that you will do. Is there anything else that you wanted to add that we didn't touch on?
I think this has been really great. As you can tell, I'm really enthusiastic about the potential for advances in breast cancer and cancer in general. And I think precision medicine is one of the ways we will get there, both for patients with advanced disease as well as early disease. And I'm really grateful you asked that question. I'm really grateful you said you were going to join Count Me In, because I think this is how we're going to make changes to the future, is by partnering and working on it together.
It makes me excited for the future. Yeah, it makes me so excited for young women, especially. Thank you so much, Dr. Wagle. I really appreciate this. YSC would like to also thank Novartis for its support of this event and future educational programs on biomarkers. You can check out YSC's Biomarker series, which also includes a Biomarker 101 section and information specifically on metastatic breast cancer. If you're interested in other YSC programs and support, visit youngsurvival.org. Thank you so much again. count me in. Count me in.
Awesome. Thank you.
Thank you.